What's up YouTube? My name is Jimmy and welcome to my channel Envisage. On today's lesson, we will discuss diabetes. We will begin our discussion with the clinical manifestation of diabetes, followed by the acronym of all the drug classes within diabetes, and finally, an overview for the treatment algorithm of type 2 diabetes. So besides gestational diabetes, diabetes can actually be separated into two different types. These include type 1 diabetes as well as type 2 diabetes. So in the underlying pathogenesis of type 1 diabetic is that it's caused by the destruction of beta cells by the immune system. The underlying pathogenesis of type 2 diabetes is insulin resistance. Insulin resistance is due to the inability of the sugar being able to be placed in the cell. So in terms of the physical identification for these patients, type 1 diabetic are usually skinnier in nature, whereas in type 2 diabetic, they're usually a little bit heavier and set. So the lack of insulin of placing the sugar into the cell may usually be compensated through either prolonged increase of insulin or with an increased amount of insulin. We can envision the extraneous sugar in the blood like the sugar coating outside of a donut. The more extraneous sugar that is present in the blood, the more sugar coating the donut will have. The test is known as an A1C. So the A1C test is a 3-month average of the sugar based on the red blood cells. So if we to visualize this chart, a 1% increase in A1C is roughly equivalent to about 30 milligrams of deciliters of sugar. In the event that patient has some type of effect in terms of the red blood cells, such as anemia, the fructose test may be used because for patients who do have anemia, the A1C may not be as accurate. Or even in the case with kidney disease, when patients have a decreased production of erythropoietin, that may affect the red blood cell, which can potentially affect the A1C and falsely lowering the A1C. Next, we will look at the clinical manifestation. So the clinical manifestation can be broken down into two different components, the macrovascular component as well as the microvascular component. So macrovascular affects bigger vessels and microvascular affects smaller vessels. So clinical manifestation that is associated with macrovascular component is heart attack and stroke. And the clinical manifestation that is associated with microvascular includes retinopathy, neuropathy, as well as neuropathy. Next, let's look at the acronym component that may help us memorize all the different classes of drugs within the diabetic space. The acronym spells out these DIBs so good. These stands for thiazolidinediones. D stands for dipeptidylpeptidase 4 inhibitors. I stands for insulin. B stands for biguanides. The first S stands for secretagogues. The second S, or sodium, or SO, stands for sodium glucose cotransporter. And finally, the G stands for glucagon-like peptide. Next, we will provide a brief overview on how these medication works. TZD increases insulin sensitivity by acting on adipose, muscle, as well as liver, but for the liver to a much lesser extent. DPP-4 inhibitors blocks the enzyme from degrading the incretin hormones such as GLP-1, therefore increasing the effect of GLP-1. Exogenous insulin helps further decrease sugar, and there is no ceiling in terms of dose, and it's more patient-specific. Biguanides increase insulin sensitivity by acting on adipose muscles and as well as the liver. Secretagogues stimulate beta cells to increase more insulin. Sodium glucose transporter prevents glucose reuptake in the paroxysmal tubule. And finally, the GLP-1 agonist is an exogenous medication that is given, and GLP-1 has multiple mechanisms such as delayed gastric emptying, stimulation of insulin release from the beta cells, and a decrease in glucagon release. And as of 2023, there is a new approved drug that is both GLP-1 plus a GIP. GLP-1 as well as GIP are primary incretin hormones during the digestion that help stimulate the release of insulin from beta cells of the pancreas. Finally, to simplify the use of diabetic medication in type 2 diabetic, we will utilize a medication schematic which highlights the benefit of the specific diabetic class of medication for the specific comorbidity. First and foremost, as counterintuitive as it may seem, the best drug for patients in type 2 diabetic is no drug. And so this includes controlling carbohydrate portion as well as exercising. The first drug of choice is metformin for diabetic patients. So metformin roughly gives about a 1.5 of A1C reduction at max dose and is also the first line of therapy in addition to lifestyle modification. If another 3 months or less have passed and the patient A1C is currently still not at level, we may add another agent in respect to the specific comorbidity. SGLT2 can be utilized in patients with heart failure with an ejection fraction of less than 40% because it helps reduce the risk of cardiovascular death. GLP-1 as well as SGLT2 are great options for patients with clinical ASCVD or those patients who have high risk of clinical ASCVD as well as these CKD patients. For patients with hypoglycemic risk, DPP-4, GLP-1, SGLT2, as well as TZDs are great options. However, TZDs should not be used in patients with NYHA class of 3 and 4 heart failure. For weight loss consideration, SGLT2 and GLP-1 agonists are great candidates of choice. GLP-1 does have 2 medications that are branded under the weight loss, which is known as Saxenda and Wegovy. So Saxenda is the brand for liraglutide, and Wegovy is the brand name for semaglutide. If, however, after multiple oral medication and the A1C is still above 10%, then basal insulin may be appropriate for the patient, since in theory, insulin does not have a ceiling dose and is individualized. And this concludes all the medication within the diabetic space. Thank you for watching. Please comment below and let me know what other videos you'd like to see next. As always, let's continue to empower a different way to achieving success. I'll see you guys in the next one.